Hello and welcome to the Perimenopause and Athletes, Perimenopausal Athletes and Beyond series. And it's a special series of experts, a small number of experts that we're bringing together to really to do a little bit more of a deep dive, but to also create conversation on the final day. So welcome. Today we have Dr. Carla DiGirolamo. and thank you so much for joining us. I am going to introduce you, but welcome.
Oh, well, thank you, Tennille. It's always a pleasure to be here with you.
Yeah, every time we have a conversation, I learn so much, and I'm able to bring into what I offer and do with my own athletes. So so my name is Tennille Hooglin, the host. In addition to coaching, I host these series. And the reason is because I really want to bring forward the best available evidence-based science into practice with my female athletes and offer this to the other coaches that are working specifically with female athletes in perimenopause and beyond, so we can do better and be better. And that's what we're about. So Dr. Carla here is what we're going to be talking about today is the essential of estrogen and testosterone in perimenopause and beyond. And where Dr. Carla comes into this is she's a double board certified reproductive endocrinologist and obstetrician gynecologist, and is a NAMS, so that's North American Menopause Society certified menopause practitioner. She's also a CrossFit trainer, certified nutrition coach, lay male body combat and body pump instructor. This is super cool, one of the Boston Magazine top doctors in the Boston area for 2019, 2020, and 2021. What an accomplishment and recognition from, people, the people, from the people that you serve. It's beautiful. And is still currently practicing medicine at the Boston IVF in Waltham. And finally, you have embarked and have taken on for change, to create change, functional fitness and nutrition coaching business called Fit for Life MD. And this is really what is exciting for us as athletes, for us as coaches, to see how an expert in hormones, in understanding, reproductive hormones, sex hormones, we could say, and in menopause, and bringing it to how do we train, how do we fuel, how do we understand these changes. So is there anything that I've missed, or that I should say more about you and what you're doing and what you're up to?
I don't think so. I think you covered it really well. It's a beautiful introduction. Thank you.
Thanks. All right. So you know what? We're just going to go let's get right into it. So my very first question is, what's happening with estrogen and testosterone over time? Like, here we are, and I'm talking specifically about the perimenopause window. And let's start from age 35, because perimenopause can hit as early as 35, not very commonly, but we want to understand before we go into this transition called perimenopause, and then the beyond.
It's an interesting pattern of what happens. So in our reproductive life, which is, we'll call it up until age 35, we can have babies into our early 40s, but for the sake of conversation, until about 35, estrogen levels and progesterone levels, they oscillate with the menstrual cycle. They're never in one place at any one period of time. But when you think about the range at which estrogen and testosterone occupy, it begins to decline into that perimenopausal stage. Now, on average, most women start to be dabbling in perimenopause at about 43, 44, 45. And to your point, it can happen earlier than that. But if we think about the bell curve and where the majority of people fall, usually it's around age 45 when we start to see an appreciable decline in that range where estrogen and testosterone live. And the main reason why this is happening is because the function of our ovaries is starting to decline. Most women have completed childbearing by the time they're 44 and don't really need, from a reproductive standpoint anyway, all those hormones anymore. Right. So it's starting to decline. And then what's happening when you enter the perimenopause, things get a little crazy for about 6 years until you get to menopause, which is defined as a year beyond your last menstrual period. Okay. So in that 6-year period where you're no longer having babies and your periods haven't quite stopped yet, your hormones are getting a little crazy. There's a lot of, I like to think of it as short circuiting because, the pituitary gland isn't quite used to not ovulating every month. So it's sending out all these signals to the ovary, and the ovary is receiving these signals saying, what the heck do you want me to do? I don't know if you want me to ovulate. You're screaming at me. Okay, I'm going to do some estrogen and testosterone, and then it'll peak, and then it'll come crashing down. And you have a very, very erratic pattern of estrogen, testosterone, progesterone, lots of hormones are just in the state of chaos for quite some time. And that's the reason the perimenopausal time is full of all these symptoms, because you've got erratic hormone signaling going on, and it impacts almost every part of the body because there's estrogen receptors, testosterone receptors in every tissue. And so every tissue in some way, shape, or form is impacted. Then once you get beyond perimenopause, and now you're in menopause, so you're a year beyond your period, everything settles out, okay? It's like a big forest fire is happening during perimenopause, and then the fire goes out. And then now you got the carnage to deal with at the end of the day. But everything settles out to a new lower level.
Right.
Testosterone levels are actually almost undetectable in women in the menopausal range. This is normal. It doesn't feel normal, but it is what is expected in that age group. Same thing with estrogen. It comes down to a much lower level than what we normally see in our premenopausal stage. Then as age continues to decline, now you got to bring the adrenal glands in. The adrenal glands doesn't really have much to do with menopause, but the adrenal glands do lose their function gradually over time. And adrenal glands do produce androgens. Those are the family of hormones like testosterone that kind of behave that way. So that's kind of a synopsis of what happens over time with our hormones. You got normal levels, you got hormone craziness for 6 years, and then you've got these much lower level sustained, beyond menopause.
Right. And one thing I probably should have asked, like, why is it that we, when in discussing, before we started this interview, why is it that we're interested in testosterone? Like, why is it, we know we talk about estrogen a lot. We know that estrogen is our hormone that is like basically a female superpower. It builds muscle. It helps our metabolism. Like, we know those things, but why is it that why is it that we're taking the time today to highlight testosterone as well?
Testosterone is just as important as estrogen for a woman. And we don't really think of it that way. A lot of people think of testosterone in a silo of, okay, it's athletic performance, it's strength, it's hair growth, it's, libido, it's all these things. But actually, if you look at the body, testosterone receptors, which are the signaling molecules that receive the hormone, they're present in just as many tissues in the body as estrogen is. They work hand in hand. Testosterone works hand in hand with estrogen in how we function every day. But it is important because it interacts in the brain. So one of the things that we encounter in perimenopause is anxiety, fear, hesitance. And many believe that the testosterone's impact on the brain affects behavior. Okay, we know during the reproductive cycle that the surge in luteinizing hormone, which is that hormone that you pick up on your ovulation predictor kits, ovulating, let's have sex now and have a baby.
Right.
That surge in luteinizing hormone stimulates testosterone in the ovaries. And what that testosterone does is it increases libido right around the time of ovulation when you want to be increasing libido. So it's evolution's way of helping to procreate the species. So that's an example of how testosterone influences our behavior. It influences our sexual behavior at the time of ovulation. But in general, it can influence our mojo. That's our mojo hormone. And when that is declining and we are feeling that, that's what it is. That's in part what it is. Estrogen plays a role in that too. But that is another thing that testosterone impacts. It also, from a physiological standpoint, impacts muscle mass. Muscle mass sarcopenia, which is a loss of muscle mass and strength through time, is a huge problem after menopause because estrogen is a huge stimulant of muscle mass as well. So testosterone does a lot of things. That's just a highlight of the few of the things that that we know it to manage.
And is there anything we need to understand in terms of like the ratio of estrogen to testosterone? Is anything that is interesting there? Like, I really don't know, like in the decline of estrogen and the decline of testosterone in that perimenopausal state, is there any symptomology or that we're aware of or experiences that when the estrogen is like, or, like symptoms, this is more a question, but a symptom happens, often it can be because all of a sudden something comes crashing down. It might be progesterone is crashing down. So we have night sweats because of that. Is there, and so that the ratio is all of a sudden, progesterone comes down, estrogen is already coming down. Is testosterone in that mix as well? And do we understand how that actually is functioning within the female body? Is that a clear question? I'm not exactly sure, but.
No, it's a clear question. It's about ratios of hormones versus absolute levels. I think more than a ratio of one to the other during perimenopause, nothing is happening in any organized, orderly way. There is a lot of chaotic secretion, and estrogen and testosterone are not staying in any one place long enough to be able to calculate a ratio, to be honest with you.
Okay, interesting. Yeah.
It's all over the place because the signals are very erratic. But when we're done with that phase, when perimenopause is done and we're settling out into the new normal, it isn't as much ratios as it is absolute amounts. Like I mentioned, if you do a blood test, testosterone is almost undetectable. It's very, very low in menopausal women. And that results, those low levels result in a lot of the muscle loss that we experience, the libido issues, things like that. Those new absolute levels rather than ratios are more responsible symptoms at that point in time. But during perimenopause, it's just the chaos. It's the chaos and the dysynchrony that's resulting in our symptoms during that.
Okay, super interesting. All right, so let's pick up on that idea of libido. So you had mentioned just earlier that right before we ovulate, we have a surge in that testosterone. Now, one thing that I experience or I see among many athletes that are in that post-menopause phase is that competitive desire, it starts to lessen among many. It's just like, I hear, and this is not an absolute whatsoever, but I hear a lot of like, I don't really care so much about, winning the trophy anymore. I want to last. I want to make sure I maintain my muscle mass. I want to keep going. I'm not losing sight of that, but my competitive desire is shifting. My desire for performance is shifting. And so, there's this like kind of this challenge that we have. And I'm wondering in your experience then, in how you work with your athletes, how do we tap into that competitive spirit then when we have this like slight decline of that push, that competitiveness that is just naturally biologically within us in terms of reproduction? Because is that clear? Because I think that one component of pushing ourselves is that sort of like grr factor. And I'm wondering how you work with your athletes or what you would recommend as a professional in how we speak to athletes and say, let's find that drive.
Yeah, no, that is a great question. And it's huge for all of us, The tough thing is that it's multifactorial, meaning it's not just hormones. There's a lot going on that results in feeling that way. So one is hormones. Absolutely, hormones come into play with this. But other things that come into play is estrogen is just as much important. And as estrogen is declining, we may not be sleeping quite as well at night. And some of the changes that we're experiencing because of these changing hormones could be straining relationships. There could be more stress in our lives. And then the big thing that really gets under my skin are the societal stigmas. When you've got your doctor that you've gone to see because you're not feeling well, telling you, and you're a semi-pro or a pro athlete, telling you it's time to hang it up. What does that do to anybody, independent of hormones, And you just have this, it's not just in the medical community, but it's all around us. It's like when people see women who are athletic in this age group, there's just something that they can't comprehend about it. And the knee-jerk reaction is, oh, you shouldn't be doing that. You're going to get hurt. Whatever the motivation is, maybe they're insecure with themselves and they're just, they feel threatened by someone who is just so, physically, more in shape than they are. I mean, there's so many factors that can make us feel this way. So I tap into this when I am seeing my clients. I try to take into account what is their big picture. Nutrition's another one too. If you're not fueling your body, maybe you're depressed, maybe you're not eating so much, maybe you've lost your appetite, maybe, you're craving sugar or you're not having as much protein. So you have one set of behaviors that is impacting other behaviors down the line. And so that particular problem, I think, is a huge, big picture, multifactorial problem. And when I'm coaching my clients, I try to take that big picture into account and help them with the mindset just as much as they're training their, maybe they're seeing me as a patient as well, and their nutrition.
I think it's so perfect because it's something that, within as a coach that I continuously bring up as well, is like the integration of all these components that we can't forget. It isn't ever one thing, and it's understanding the questions, and the responsibility of the coach is to start to try to bring out these questions into a practice and to highlight those changes and those realities that we're part of. So amazing. So let's get into now understanding how exercise can alleviate the effects of these changing hormone levels. So first, what are we talking about when we say exercise? Like, so this is one thing, is like, what is an athlete and what is exercise when we're talking about this? Is it lifting heavy? Is it HIIT, regular endurance, or is it all of it? Like, how can we contain this about when we exercise, we can alleviate? Is it anything?
So, it's interesting to define athlete is like defining fitness. The CrossFit world has published article upon article about what the definition of fitness is, and it's really up for debate. And I think the defining athlete is similar. To me, in my humble opinion, I think an athlete is anyone who intentionally, on a consistent basis, participates in physical activity. Now, that could be anything. That could be team sports. That could be just going downstairs and getting on your Peloton 3-4 times a week. It's intentional physical activity. Exercise, I mean, I think yard work is exercise. If anyone has gone out and mulched their yard and pruned trees, knows that you're going to be sore for a week after you do that. So although it might not be an athlete going out there pruning their trees and mulching their yard, it's certainly exercise. So I think exercise is any intentional physical activity that you do on a consistent basis. Now, to what degree that is depends on your baseline level of fitness. So someone who is sedentary, going out for a walk for 30 minutes 3 times a week, that's exercise for them. The marathon runner, that's not really exercise for them. I mean, they're used to running 10 miles at a time. Exercise for them is, they're running, or maybe they're getting into the gym and they're lifting. Either way, for either person, it's intentional physical activity that's being done on a consistent basis. Now, different types of physical activity are going to stimulate the body in a different way. When you had mentioned this as one of the questions you wanted to talk about today, I did do a deep dive into the literature to look at the role that hormones plays and the cause-effect relationship between exercise and hormones. And so what I was reviewing, and what I kind of knew but had to refresh my memory on, is that when you engage in exercise, particularly lifting heavy, that would be like smaller reps, 5 to 10 reps of weight bearing, like squats or deadlifts or curls or shoulder presses, over, maybe 5 sets with some rest in between. That would be an example of this type of stimulation. That stimulates in the short term for 15 to 30 minutes after exercise, increases in testosterone, increases in insulin-like growth factor, and many of the other anabolic or synthetic type of hormones out there that promote the body building upon itself and recovering and getting stronger. There are also catabolic things that are secreted in that time, and that's your cortisol, which is your fight or flight response. That's your epinephrine. Those are the things that come from adrenal gland that help you to say, okay, I'm faced with this physical task, I need to do it. So that's kind of what the hormones do in response to exercise for about 15 to 30 minutes after you do it. Then after the exercise is over and the physical task is completed, your hormones kind of go back to whatever baseline they were at the time. So you can't change hormones by doing exercise for hours and hours and hours after. It's really more surrounding the time of exercise, okay? Then you have, well, what about the effects of your hormone changes? That is the effects of having low estrogen, the effects of having low testosterone. What effect does that have on our exercise metabolism and our food metabolism that we can then target? So that's the distinction. There's the effects, which are what we deal with on the long-term end, and there's the immediate hormonal changes that happen in response to the physical thing you're doing in that moment.
Super interesting. I don't know if you had time to understand, does estrogen also peak within that 15 to 30 minute window post, is it like testosterone? Because I have heard, and, in the literature, there is quite a lot of evidence in saying that testosterone increases, but I don't know. I can't seem to pinpoint estrogen being discussed much or measured. Did you?
It wasn't. I ran into that too.
Right.
It's mostly the hormones that are looked at are testosterone, insulin-like growth factor, and growth hormone. Those are the 3 biggies.
Yeah.
Estrogen isn't really a huge anabolic hormone in those acute situations. Okay. It is very anabolic over the long term, and it's important for muscle function in women. Over the long term, but in terms of that acute reaction to exercise, it's more the testosterone, more the insulin growth factor and the growth hormone.
Okay, so that's super. And that also points to then the nutritional need, right? So in that acute sense, is this why that window for fueling is so absolutely important in terms of protein and carbohydrates for the uptake, to ensure that we're maximizing the effort through the strain?
Absolutely. They're tied together. So the hormones are like the eyes, right? They see the physical task and they react and say, okay, muscles, we got to get moving. We got to get going here. It gets the nervous system and the muscles moving, but you got to have gas in the engine if you're going to go anywhere. So your muscles have to have glucose stored in them. The protein has to be there for the structural integrity of the muscle. So this is why it is important to fuel beforehand, because you want to make sure that when the hormones in the nervous system sense there's a physical task to do and it ramps up, that you've got the fuel in the tank to be up for the task, so to speak.
Yes.
And then recover afterwards. Then you have to recover. You have to refuel the tank after the physical task is done.
Mm-hmm. Mm-hmm.
So they're inexplicably tied together.
Absolutely. Yeah. I've been doing some experimentation in this whole thing because I'm fascinated by the intermittent fasting. We have somebody that's going to talk about this specifically, and to understand, okay, well, what is this fueling for training actually happening, and how does my body actually respond? And I'm doing a super in-depth understanding of it just from one case study. And then so we can explore this more, because there's so many benefits on either side. And obviously it depends, like, well, what's your priority at the end of the day? So,
right.
So interesting. Okay. What so when we're thinking about, okay, there's two questions that I have on this is one, when you're talking about load 5 to 10 reps, I think this is important because we have such a range of people in undertaking our intentional exercise. Doesn't matter if you have a 5-pound bell or a 44-pound kettlebell that you're swinging or something like that. Like, is it heavy to you when you're doing the strain that matters? And I think this is a super important point to make. Heavy to you versus you have to, it doesn't matter unless you're lifting 25, some fictitious number.
Oh, goodness, no, it's absolutely heavy to you. So one thing that people don't think about as lifting heavy is push-ups. I love to use push-ups as an example because if you've ever tried to do a strict push-up, meaning on your toes, your core is braced, you go all the way to your chest touches the floor and go back up again, those are hard, okay? And, you know, I tend to be pretty good at push-ups, and I'm a CrossFitter and we do them all the time. I don't think I can do more than 7 or 8 in a row without resting perfectly. So anything that is like around the 5 rep range, you know, 3 to 5 reps, that's heavy, you know. So a lot of the people that I train, they can't do more than 3 of those strict push-ups at a time. So when I have them doing like every minute on the minute, you're going to do 3 push-ups and you're going to use the rest of that minute as reps, as rest, that's a heavy day. When even though you're not lifting a single weight off the ground, you're lifting your body weight and you're putting that kind of strain on your muscles. So even push-ups for people where it's difficult, and it is for most, that is one, I consider it a heavy lifting day because your body's heavy.
Yeah, I think it's really important to remind people that it's that, is it heavy? Is it hard? Is it deliberate to you? No matter where you're at, because we think of progression. Okay, maybe it's 3 this day, but maybe, you know, in a year or year and a half, you're going to be doing 10. And then maybe it looks a little something different and you take on a different form of a push-up. And I haven't gotten to those different, you know, modifications, you know, one-legged and all those things. In any case, okay, does it matter when we think about our exercise and how it to alleviate the effects of our changing hormones, how we do things? So in terms of doing strength and then endurance after, or do we do our endurance and then our strength after? Because limitations of that are real in our days, right? So is there anything that we need to understand about lifting heavy and then doing an endurance workout or a HIIT workout immediately after? Is there any rules that you have for that or thoughts?
I think I have a lot of thoughts about it. I'm going to backtrack a little bit because I want to lay the foundation for the answer.
Okay.
So when we're thinking about the effects of our changing hormones on our muscle physiology and on our, you know, nutritional physiology, we'll talk about muscle for now. An example is with insulin resistance. Okay. We become more insulin resistant because estrogen declines, and a lot of that mechanism comes from the muscles, because the muscles are the largest organ in the body and they use more glucose than anything else. And the estrogen can modulate the way muscles use glucose, right? So as that declines, now the muscles don't have the same stimulation to use sugar. But the body is brilliant because the body has wrapped within it lots of different backup systems to get the task done. So the muscle has to use sugar to function. If the estrogen isn't there, it's got to do something different, you know. And this is where, this is where fueling becomes more important. You want to make sure you got more glycogen in the muscle stores. You want to make sure you got more protein. You have to compensate now. So compensation is one of the main ways we can overcome the effects of hormones. We just have to tap into those backup systems that our body has to accomplish the same task. It's going to be a little tougher because now you're missing something. And you know, that something, you know, may not be coming back or will not be coming back. So you kind of have to tap into the backup mechanism. So one of the things that muscle and the whole body likes is constant change. It's adaptation. This is what keeps us fit, is the body's ability to adapt to different stimuli. And this is the single best way to stimulate the body and get around the fact that the estrogen isn't doing that stimulation anymore. I think Stacy Sims covers this really well in one of her courses that she gives, the Menopause for Athletes course, is that when you're missing that stimuli, you need to overcompensate using your body's brilliant backup mechanisms to still continue to go and to continue to be fit and be healthy and be, podium level athlete, if that's what you do.
Yeah.
So in that vein, the way you want to deal with your training is you want to constantly mix it up. You have to keep your body guessing, because that will keep your body stimulated and take the place of that stimulation that is no longer there with respect to the hormones. So I don't like to do like a long endurance day on a heavy lift day. I might do a short endurance day, to warm up. I might go out and run a mile at an easy pace. Might take me about 10 minutes or so. Come back in, I feel pretty good, maybe do a few air squats and then start my heavy squat day. But I probably wouldn't do a 5K on the same day I'm going to do a heavy squat day, because you deplete the fuel out of your muscles. Your muscles can only deal with so much at any one time. So yes. So what I tend to like to do, you don't want to take one away from the other. So you don't want to do heavy endurance on the day that you're going to do a heavy lift. You want to separate those out. Now, that doesn't mean don't do any endurance. You might want to, for me, I'm not a runner. I'm just kind of getting out there running, when I have to. It's a good warm up and I do enjoy it. I might go do a mile and, it takes me about 10 minutes or so at an easy pace. And then I can come back and I'm like, all right, I'm ready to go squat, do a few air squats, warm up your hip flexors and everything. And then I can get at it with a nice heavy day and really have a good day.
Mm-hmm.
I wouldn't want to run a 5K. For me, that's a lot. I know for some of you guys, it's like a warm up, but for me, that's a lot. I wouldn't want to run a 5K, which takes me about a half hour, and then try to go do my heavy squat day, because I'm going to be toast at that point. And the muscles are just like, look, I just ran 5K. Now you want me to squat?
Like why?
It's like, yeah, diminishing returns. So if you're getting the most from your heavy day, do it separately from your long endurance days. Have your long endurance day be your long endurance day, but separate them out, because you'll be able to do more and activate those fast twitch muscle fibers much more effectively on its own day than if you did a long endurance run.
Excellent. Okay. Thanks for that. So there's really 2 points that I just want to really hammer home. It is, you talked about the strain, the adaptation, switching things up. So that's part of it. Keeping your body guessing is, I think, brilliant, because it's, the person who continuously runs every day, the same pace, the same route is losing the deliberate and intentional strain that might be coming. And that's where we might see plateaus in performance or lack of inability to maintain or build muscle mass, because we're not creating change. And then the other thing is, again, being deliberate in what is it you're trying to accomplish on that day. Be intentional.
Exactly.
Yeah. Okay.
Plan it out with your coach on your own and just say, okay, I'm going to have 2 heavy lift days this week. I'm going to do, 2 or 3 endurance rides. Maybe you're training for a race in a few months. Maybe you're training for the Boston Marathon. And definitely mix it up. And you never, ever want to forget your mobility and your yoga, because your mind and your joints need to recover. And mobility and yoga are great, great things for recovery, which is something we have to pay a little more attention to, because as those hormones decline, our ability to recover changes too.
Yeah.
And so we need to pay special attention to that. And again, tap into our body's backup mechanisms when it no longer has estrogen to still accomplish the same goal.
Absolutely. Interesting. Okay. So what I want to just finish off here in this interview is talking about some of the things that we can do to support our body in these changes. So we've talked about exercise being one of them and how to exercise, but let's talk about, there's two things specifically is that I've been reading about and others have asked me about something called dehydroepiandrosterone, which is otherwise known as DHEA. I don't know if I totally like trash the way one says that. And it helps alleviate some symptoms of perimenopause. It helps improve bone health, reduce inflammation, because it makes androgens and estrogens. So how does this work? And is this something that we should talk to our medical professional about? You know, like, is this something to be curious about?
I definitely think it's something to be curious about. In menopausal medicine, there is an FDA-approved DHEA product for vaginal use to help with painful intercourse due to vaginal atrophy. So the tissue in vaginas, it tends to get thinner over time with the lack of estrogen. It can get very dry and sex can be very painful. So prasterone, I think is the generic name for it, is an FDA-approved DHEA product that's meant for vaginal use, and it's very effective in helping women with painful intercourse. Right now, that's the only FDA-approved product out there for DHEA that has some study behind it and efficacy behind it for a specific purpose. In terms of what DHEA does, like when we just take it as a pill, DHEA is it's called a prohormone because its main purpose is to turn into estrogens and progesterones. That's its main goal. And the way each tissue processes this is very, very different. So imagine that Home Depot comes to your door with a load of 2x4s, right? If Home Depot delivers that to your house, you or your husband may do one thing with those 2x4s. If the truck delivers it to the builder down the street who builds houses, those 2x4s are going to become a house. If you deliver it somewhere else, it might just become firewood. So how the hormone is processed depends on the location of where it arrives, right? So the brain may not have much use for DHEA, but maybe hair follicles do, or maybe the digestive system does. And that's what makes it really confusing. As we take this stuff, it goes all over the body and it's processed very differently in different places. So there isn't a lot of good study out there on efficacy for other things other than the vaginal application that I just mentioned. But it's a hormone that's been interesting for a very long period of time. It's very interesting to my patients undergoing infertility treatment. It's been out there used as an ancillary hormone for ovarian stimulation for many, many, many years, for decades now. But it's very hard for us to put our finger on whether it works, what it does, because it's processed so differently in different tissues.
Isn't that something? And here we are talking decades, and like, how mysterious and phenomenal are our bodies? Like,
yeah, sure.
Studied, looked at, used, known, how, not so sure. Isn't that just so cool? Okay, let's tap into the other hormone therapy. And what are the considerations for that? And when do we start asking ourselves whether it's right for us?
Yeah, that's a great question. And you really want to see a provider that's skilled in menopausal medicine, who really understands what menopausal women are going through with the symptoms, the physiology changes, because hormone therapy is great for certain things and it's not great for other things, and it can be risky under certain circumstances. So you want a provider who can take your particular situation and apply hormone therapy, risks, benefits to you. So, a no-brainer is if you're dealing with hot flashes and they are debilitating your life and they are significantly impairing your ability to function on a day-to-day basis, we know that estrogen and progesterone therapy is a very, very effective tool to manage this. And so, it's great, but in some people, say, for instance, you have a blood clotting disorder, and you've been on anticoagulants for something, estrogen therapy may not be right for you, because it could be dangerous under those circumstances. So, and then there's other indications for hormone therapy that are more questionable. It's like, well, do we prescribe hormone therapy to prevent osteoporosis? Yes. Do we prescribe hormone therapy to treat osteoporosis? No, we don't.
Mm.
So it's complicated. And then this testosterone. Well, when do we use testosterone? Basically, for me, I use testosterone once I've exhausted my estrogen therapy options for a patient. If she's still experiencing certain symptoms after I've exhausted the estrogen therapy route, then I may add testosterone to that, because testosterone gets converted to estrogen in the body. So like, you can treat someone with testosterone and the effects that you see might be because it's just being converted to estrogen. So that's why you want to exhaust your estrogen therapy first. And then that might cure, whatever it is you're dealing with. And if it doesn't, then testosterone therapy might be something you want to think a little bit more about. But everybody is unique. Everybody has different circumstances, and it really would suit you well to get a provider that is skilled in being able to evaluate this for you.
Mm-hmm. I think what's also interesting that you said, and what my knowledge is that there is a lot of, you said you exhaust your estrogen therapy. Like, there's more than one, there's more than one way to start looking at what hormone therapy is. There's a lot of different variations in that. And so if one protocol isn't working, are you in the guidance that you have from your healthcare provider going to help you work in to say, well, maybe there's this one, maybe this will work better, and to really get curious about what are the numerous ways that we can start investigating this?
And it's a lot of trial and error. I mean, when I'm prescribing hormone therapy for my patients, I'll start them on something, and then they may say, okay, I've been taking this, but my boobs hurt, they're swollen, I feel nauseous all the time. And that tells me, okay, maybe she needs a different type of progestin, or maybe she only needs progestin 5 days out of the month instead of continuously with her estrogen. Maybe she's so averse to progestin that maybe she needs an IUD, and then we just use straight estrogen therapy. There's so many different combinations of things, and every woman's very different. It's hard to predict what's going to work for who, but there's a lot of trial and error there. And that's kind of what I mean about exhausting the possibilities. If I can't, with the toolbox I have of estrogen and progesterone therapy, find a combination that works for her, then maybe it's time to start looking at testosterone therapy.
Right. Super interesting. Wow. Okay. So we have covered a lot of ground.
And we always do, Tania.
We always do. It's so brilliant. So is there anything that you wanted that we haven't discussed that you think that we really need to ensure that the listeners hear in the context of what we're talking about here, estrogen and testosterone and exercise? And we talked about how to apply it. We've talked about therapies. Anything else that you wanted to say?
I think like I mentioned, finding a healthcare provider that is experienced in dealing with menopausal women, particularly if they're a NAM certified practitioner, and it's not like NAMs are the only good practitioners out there. They're not, but at least that they've gone through very, very rigorous and specific training in menopausal medicine. But somebody who is very well versed in this. And in terms of your fitness, you want to get a coach. I can't stress enough how a great coach can really make a huge difference in your life, because your coach is going to tap into the mindset, the nutrition, the fitness piece. And that is all so incredibly important for our quality of life and how we are as athletes going forward. I am a different athlete now at 51 than I was at 31, because circumstances change and our bodies change, and I have to figure out another way to get to point B. And it's different now as opposed to 20 years ago when I was 31. And so coaches can help you tap into that and figure out, okay, it's different now. How do I tap into those alternative mechanisms to make sure I can still get to point B?
Yeah, it's the deliberate intention component of it that helps you move and move beyond what is that comfortable. It's the stretching that we provide as coaches that I think is really, is what, and the accountability too, as well. So interesting. Okay, so we are going to be all coming together as a panel after this series of interviews are released. And I just want to have you share a little bit about what you have gifted to a certain number of people that we'll have a draw for at that particular that session, that live session. So can you just tell us what the 2-week functional fitness offer is?
Yes. So what I do as part of my Fit for Life MD company is I do functional fitness programming where my clients get 3 functional fitness workouts each week, and they're different. And that is a subscription. And they get this, week over week for however long they sign up. So I'm offering that 2 weeks of that as a giveaway, and I am also willing to offer 2 30-minute consultations live with me personally over Zoom or over phone, whatever is convenient for your followers. I'm offering up 2 of those in addition to the subscription for 2 weeks.
It's amazing. It's super cool. So come and join us live after you've heard this, and sign up and make sure that you're part of it, because it's going to be awesome and it's going to be interesting. I can assure you on that one. So, and if you have questions after you have heard this interview, then we absolutely want to know. So please send us your question by email. It can be also sent to me by direct message on Facebook. It can be posted in the Athletes Thriving in Perimenopause and Beyond Facebook group. So numerous ways to share. And we look forward to seeing you in a couple of days. So thank you so much, Dr. Carla. It was amazing.
Oh, you're very welcome. It was a pleasure.
All right. Bye-bye.